Today, Anne has asked me to speak about fertility, childbearing years, and beyond, which is a topic that I speak to my patients in clinic often, but I don't usually speak about it in this type of setting, so thank you for taking me out of my comfort zone. And also, one of the other things I was going to say is that when I was listening to Dr. Mesa speak, you know, there's many things in the care of MPN patients that are very black and white, based on science. We have really good understanding of things, and there's kind of like one right way to do things. What I'm going to speak about today is not necessarily that. And so a lot of what I'm going to recommend or say, you may have heard something different, and so I look forward to hearing your questions and thoughts because there's probably more than one way of addressing many of these issues. Anyway, so today I'll speak about kind of fertility considerations for women with an MPN. Pregnancy, different considerations of pregnancy, complications, and treatment, some issues about contraception, and then I'll speak a little bit about menopause as well. So as you all know, the majority of patients that are diagnosed with a myeloproliferative neoplasm are diagnosed in their 60s. However, up to 20% of patients with MPNs are diagnosed when they're less than 40. And therefore, fertility and contraception are definitely relevant issues to a significant part of the population with MPNs. The most common MPN to be diagnosed in younger women is essential thrombocytosis, followed by PV. And MF, although it happens in younger women, is the rarest of the three. In general, unrelated to MPNs, women are pushing the age at which they have their first child. And in addition, we are now better at diagnosing MPNs. Therefore, we have higher prevalence of women that are older when they're having their first child and have a higher likelihood of having additional comorbid conditions during their pregnancy, including MPN. So the first question to think about if you're a patient that's young and possibly are contemplating starting a family is, does having a myeloproliferative neoplasm affect my fertility? So the MPN by itself, unlikely to affect fertility. Now, there's some aspects of the disease that may affect fertility. For example, there's some chemotherapy regimens that can definitely affect your ability to become pregnant. Thankfully, for the majority of treatments, especially for younger women, they are unlikely to affect your fertility in the long term. So for example, if you're on hydroxyurea, stopping hydroxyurea will probably result in normal fertility after that. Other therapies such as interferon not only do not affect fertility, but are actually safe during pregnancy, and I'll talk about that more. And to follow the theme of what's been said throughout the day, really when thinking about starting a family, having an honest discussion with your MPN provider is really important to really discuss, what are some specific things that I need to be thinking about if I'm a woman that has an MPN and I'm going to get pregnant? What is my prognosis? What are potential complications that I may be experiencing? And so being an informed patient, like I know all of you are, is really important so that you can plan what's best for you. The next thing to think about is what medications you can take while trying to conceive and also during pregnancy. And so what medications can you take while pregnant? Well, you can take some medications while trying to conceive, but there's some medications that you definitely can't take. So aspirin is definitely safe to take while trying to conceive, but also during pregnancy. And aspirin is critical to take during pregnancy, and I'll talk about that more. Interferon, also safe during trying to conceive and during pregnancy. And then the others, well, you will have to have a discussion with your doctor. How much do you really need to be on that medication? Can you take some holidays from that medication while you're trying to conceive? And then will you have to switch medications once you become pregnant, or do you have to have a time when you're off of these medications? So this is where the art of medicine really comes in to really discuss, what can I be on and what should I stop? So specifically, what are some pregnancy considerations? So like we said, know which medications you can be on and which medications need to be stopped. And then talking about pregnancy specifically, there are risks. Any pregnancy carries risk for the mother, and of course there are always potential complications for the mom and for baby, so that's not specific for MPN. Pregnancy is a condition where The mom is at higher risk for having bleeding and blood clots. And that's true regardless of any other conditions that are going on. Specifically in MPN, as we all know, having an MPN increases your risk of having blood clots also. So pregnancy is a time where MPN patients definitely need to be observed more carefully. The blood clots outside of pregnancy can affect us in many different ways. They can be clots in the legs, clots in the lungs, etc. In pregnancy, they can affect the actual pregnancy itself by affecting the placenta, the growth of the baby, and can increase the mom's risk of having blood clots during pregnancy and afterwards. So I think it's really important not only to have a good relationship with an MPN specialist, but also consider having a relationship with a high-risk OB, somebody that's familiar. Perhaps not, you don't have to have a specialist that is an OB that also treats MPNs. I think that there's probably not that many of those around. Not everybody's Dr. Corey. But at least somebody that's familiar with having blood clots or that kind of thing during pregnancy. So we've talked a lot about risk stratification in many different conditions, and this is, in pregnancy, it's no different. So there are women that can have an MPN and get pregnant and have low-risk disease, and women that are higher risk. And like when we're thinking about approaching ET and PV outside of pregnancy, we use that risk stratification to determine what type of treatment we need to provide our patients. So what do we mean by low-risk pregnancy? Well, this is a woman that has never had a blood clot before, a woman that has never had any abnormal bleeding that's related to their MPN, and somebody that's never been on blood-lowering therapy specifically. A higher risk pregnancy would be the opposite of all of those things. So have you had a history of having a blood clot or abnormal bleeding related to the MPN? Have you previously been on blood-lowering therapy? And the other thing is, have you had any complications previously with your pregnancies? And so then treatment is determined based on that. So for basically any woman, unless there's a real contraindication to that, aspirin is not only recommended, but highly encouraged and very important to preventing pregnancy-related complications. If the hematocrit is greater than 45, then similarly to how PV is treated outside of pregnancy, we would try to lower that hematocrit. In pregnancy, blood counts tend to go down actually, kind of naturally, so both the hematocrit and the platelets will naturally go down during pregnancy, so it's likely that that won't be as much of an issue during pregnancy, so at least there's that. And then there's a specific consideration of blood thinners. So for women that are low risk, even for those that are low risk, we recommend at least a prophylactic or a preventative dose of a blood thinner to be given 2 weeks before expected delivery and up to 6 weeks after. And for women that are high risk, those that have had prior blood clots, we recommend at least a preventative dose of a blood thinner throughout pregnancy and for the 6 weeks after. So even after delivery, there's still a lot of hormonal changes that may be occurring that may increase risk of blood clots during that time. And again, although these are the recommendations that I'm putting here, and these reflect what's written in the national and the NCCN guidelines, this is not hard and fast and based on like large studies that have compared, thousands of women. This is a lot of consensus guidelines and based on experience with pregnancies and other related situations where women maybe have had issues with blood clots before. So if your doctor has maybe said something different, there's a good reason for that. Kind of a few nuanced things, and this is where it's a little bit difficult to really plan. We recommend stopping aspirin and stopping the blood thinner close to the delivery date. Of course, it's sometimes not easy to know exactly when the baby is coming, so that's will require a day-to-day conversation with your doctor. For women that are higher risk, interferon is really the only medication that is routinely recommended to lower blood counts. And surprisingly, there's really not that much published about interferon specifically for MPN, and really not a lot published on the pegylated interferon form of pegylated interferon in general for pregnancy. So this definitely requires a conversation with your doctor to decide what type of therapy is right for you if you need anything. And then another thing that I wanted to add is that after delivery, hydroxyurea can't be given if you're planning on breastfeeding, because that does cross into the breast milk. So then I wanted to talk a little bit about our experience with pregnancy, kind of to highlight a little bit about what is known and what isn't known. There really isn't that much published about pregnancy experience in MPN, although there are a lot of other series that are similar size to ours. But this was a good opportunity for me to review our own research that hopefully we'll be presenting this year at one of our conferences. So with the help of one of our amazing fellows, we put together a database of 130 pregnancies in 60 patients, most of which had essential thrombocytosis. And these patients were taken care of at Mass General, where I work, at Beth Israel, Dana-Farber, and Brigham and Women's Hospital. The majority of patients had a JAK2 mutation, and the live birth rate was about 70%, which is really not that different than the general population. There were cases of spontaneous abortion or pregnancy loss before week 20, which, although that number seems high, it actually occurs definitely a common occurrence in normal pregnancies or women that don't have any other diseases. There were only 2% of women that had blood clots during pregnancy and 7% that had any bleeding related to pregnancy. So what did we learn? There's definitely an opportunity to improve outcomes. What I found encouraging is that treatment has changed in the last couple of decades. So some women in the past maybe weren't treated the same way, weren't recognized to have an MPN. We didn't have a lot of consensus guidelines to help us decide how to treat women. So I think that in the more recent years, the outcomes have gotten better. The live birth rate is similar to the general population, and in general, women did pretty well, which I thought was pretty encouraging. And the most important thing really is that aspirin use is critical. Women that used aspirin definitely do better than women that don't use aspirin during pregnancy. And then the other thing is that if you've had a pregnancy complication in the past, you're at risk for having more pregnancy complications in the future. And this is true not just if you have an MPN, but in general. So that's all I'm going to say about pregnancy. Now to move to preventing pregnancy, so birth control and MPN. And here again, there's really not a lot of data. There's not a ton to guide us. And so I don't even think that a lot of this is even in the guidelines. So there's maybe been a few small studies, but in general, being on birth control, especially estrogen-containing birth control, increases your risk of having blood clots. This is regardless of having an MPN diagnosis. So what I tend to tell my patients is to avoid estrogen-containing birth control. Now, this is, again, not an 100% thing. There are some women that the other types of contraception, the progestin mini pill or the Mirena IUD, that are the progestin-containing types of birth controls, just don't work for them. And if they're very young, have a calreticulin mutation, don't have any cardiovascular risk factors, which is the majority of women that are thinking about birth controls, and occasionally it's okay to think about regular birth control, but this again requires a conversation about risk. So I spoke about what the options are for non-estrogen containing hormonal contraception. And again, kind of going back to the theme of what I've said before and what others have said before me, having a good relationship with your doctor about the risks of being treated or not being treated, or being on contraception or not, is really important. So I know that others have spoken about this before me, so I definitely won't talk about all of these issues like my other colleagues have. But in general, I think it's worth repeating. We can talk about fertility, we can talk about pregnancy, but I think probably a much more common problem in MPN, probably because more women are older than 40 or thinking about having children, is really just libido and sexuality-related problems. And so, of course, if you're uncertain about your diagnosis, if you're uncertain about your prognosis, and you're thinking about these things, that's natural to affect libido. You may have symptoms such as night sweats, itching, headaches, bone pain, abdominal pain, fatigue, which of course is like the most common side effect. Or if you have any side effects specifically from the medication that you're on, this is something that is going to affect your libido. And as I was planning these slides and I was talking to a few of you yesterday in clinic, I realized that this is really not a topic that we speak about that much in clinic. We're always focused on what does the blood work show. I ask about, the MPN symptom assessment form, which doesn't include sexuality. And so we don't bring this up that much. So I think it's important to not be afraid to speak to your doctor about these things. It is important. It's not complaining. It's not trivial. And it's just as important as talking about blood counts and talking about side effects and talking about how you should be treated. Because having a good understanding of your disease, having a good understanding about prognosis, making sure you're feeling well can help not just your blood counts, but also can help, you all around, and especially your libido and sexual function. So sexuality and MPN, again, this has sort of been mentioned before me, but just to kind of reiterate, all patients with an MPN or with any chronic medical illness can be at risk for having issues with sexuality-related symptoms. In the studies that have been done for patients with myeloproliferative neoplasms, certainly patients with myelofibrosis are generally the patients with the highest symptom burden and tend to be affected more than patients with polycythemia vera. Patients with PV tend to be affected more than patients with ET, but again, it's not the same for everybody. Patients with low blood counts on treatment and with transfusion needs definitely are the ones that are affected the most. Patients that are older tend to be affected more than patients that are younger, but again, everybody is at risk for having any symptoms that can affect sexual desire. So again, don't be afraid to talk to your doctor about this. It is just as important as talking about your blood counts and about all of your other symptoms. Controlling MPN-related symptoms can definitely help. Like has been said before me, if you're feeling well, and you feel like you have enough information about your disease, you're more likely to be at ease, you're more likely to be able to think about things outside of your MPN. And so then the last thing that I'll talk about is menopause a little bit. And so it's difficult really to know what your symptoms are related to. And this is not just true of menopause, but of many different things, like thinking about fatigue, thinking about headaches, thinking about abdominal pain. Many of the symptoms that we deal with as MPN providers and patients are difficult to sometimes determine their cause. Is this the MPN or is this something else? And so again, discussing with your doctor is important. Seeing your doctor frequently is important. If you're having a lot of symptoms, it's not okay to wait 3 or 4 or 5 months to see your doctor again. See your doctor again sooner and talk about just these symptoms. The difficulty of the fact that you can't always distinguish what's causing what is that this is where a little bit of art is required and a little bit of trial and error is required. And all of that can only happen if you can have an honest discussion with your doctor. So specifically related to menopause and, for example, hot flashes, some patients, even men, will have, kind of hot flash type symptoms during the day, not just at night, the night sweats. And so sometimes it's hard to know what's what. But if MPN-directed therapy to lower blood counts or doesn't lead to an improvement in those symptoms, then maybe it's time to say, okay, maybe we need to talk to the OB or to your primary care doctor, or we need to think about some therapies that are more geared at treating menopause. And so we may not be able to fix absolutely everything, but at least we can try to make those symptoms better, to go, like Dr. Mesa was saying, take you on your path to wellness. So even if we can't make everything go away, we can at least make you feel better, or at least that's the goal. And I think that's all I have to say. So thank you so much. Happy to take questions.